Good morning and a warm, I should probably say hot, welcome from New York City to those around the world joining us today for Intravascular Imaging Live, our exciting live case series from CCC Live Cases, broadcasting as always from the Cardiac Catheterization Lab at the Mount Sinai Hospital in New York. I'm Nitin Barman, the moderator for today's session and proud alumnus of this very lab, current Cath Lab Director at Mount Sinai Morningside. So today we're excited to present to you our 9th live case in the Intravascular Imaging Live series. It's another very instructive case today utilizing IVUS to assist in the evaluation of indeterminate left main disease and significant LAD ISR, the types of lesions that would likely be commonly encountered by most interventionalists. As always, one of our primary goals to the series is to demonstrate the value and technical execution of intravascular imaging from a fully practical point of view, with the hope that this will translate into more appropriate and significant utilization in our audience's practice. So with that said, let's get started. As always, we'd love to hear from you in our interactive chat, so please send us your questions right through the website or on YouTube. I will be monitoring the chats throughout the session, and as always, your participation adds a great deal to the program. The full case will be posted on our website, www.ccclivecases.org, as well as our YouTube channel in the next day or so. So if you're unable to see today's program in its entirety, definitely check out the archived form. As mentioned, we have a great 9th case for you all today. So let's head over to Dr. Kinney and the team in the Cath Lab at Mount Sinai Hospital for today's live case. Dr. Kinney?
Yeah, good morning, everybody. And we can start showing the slides. I have myself, I have Amit Huda. Our new fellows have joined for this year. We have Dami, who is a chief fellow for this year, and Prithvi, who was a research fellow last year, but right now he's doing his interventional fellowship with us. So this is the case of assessment of left main and PCI of the diffuse LAD ISR. So just going to show the slides are not.
There you go.
As you see here, nothing to disclose. So this is the case that we have, a 69-year-old male with history of hypertension, hyperlipidemia, non-insulin dependent diabetic. Hemoglobin A1C is 6.8, but more important, if you see here, his lipid parameters, are well controlled with the LDL of 60. Then he had presented with angina class 3 to an outside hospital. So in the clinic, in the past, he's had a prior PCI to LAD in 2008, 2014, and maintained, his EF has been maintained. So he did have positive stress test also with on top of angina. So if you see medication wise, he's on good medical therapy, which is just on atorvastatin. His LDL is 60. So he had a cardiac cath at an outside hospital, which had revealed left main 3 vessel disease. Then he was referred for bypass. Then what happened is he went, met a surgeon, and had multiple discussions with a few other cardiologists and interventionalists, and decided he did not want to have bypass. Then came back to Mount Sinai. So what we did was we did the PCI of the circumflex. RCFFR was negative, though RCA was called as a significant disease in the outside angiogram. And then after that, we did the PCI of the circumflex. Today he is here for evaluation of the intermediate left main as well as his LAD, which is an ISR. So when he came to see me in the office, since it was LAD ISR, diabetic, even I told him that, ideal would be that he should go for surgery, but I think he was totally not ready to have surgery. We are okay? Angiogram, one cranial picture. So we are going to do a one cranial picture and show you the angiogram. So today, it's not working, is IVUS-guided left main assessment and a PCI of the diffuse LAD ISR. So same thing, diabetic 3 vessel disease, questionable left main, always the first thing is that appropriateness wise he should go for surgery. Heart team discussion. Heart team discussion is a key which he had, and after heart team discussion, it's been decided he's a candidate for PCI. So that's why it becomes an R. So if you see here, this was his old angio 80% proximal circ as well as involvement of the OM1, which was a bifurcation. We put one stent that is from circ to the OM. This was his final picture. So if you see the right coronary artery, the FFR was 0.92. So just to show you, when we are going to go through this imaging, what are we going to do? These are the two new technologies that have been introduced in the last few months. The OCT by Abbott now has a new software called as Ultron 3.0, which is an AI assisted OCT, which made the biggest thing is the faster pullback, and now they have automatic lipid detection. In the past, it used to be only automatic um, calcium detection. So now we have automatic lipid detection also. So the lipid is blue, if you can see that. Calcium, if you see, is orange, and lipid is blue. There is OCT derived FFR also, but FDA has not approved it in the US, but it should be out soon in the next couple of months. Then we have the spectra wave, which is called as a deep OCT, which also has lipid. In that, if you see the lipid is showing as deep OCT plus NIRS, which is with lipid, which you can see in the side. But more important, if you see that they have angio-derived FFR, not OCT-derived FFR, angio-derived FFR, and they call it as X1 FFR. So what is happening is everybody is trying to use one particular technology, one device, and trying to use computational biology and flow dynamics to get multiple outputs just by one particular thing, because then you have CathWorks, which is giving you an FFR based on the angiogram. So you have to know all this, and you maybe try to use one or two of these devices if you need to use them. So Terumo came up with what is called as IVUS, and they call it as OFDI, which is their term for OCT. And if you see that, you can have IVUS and OCT. So the question is, in which cases? Certain cases you may need both of them together. So both of them we have upgraded Abbott way back in May, and Terumo also just around that time. We were the first one to do the first in human Opus case, which also was covered. If you see that OFDI and IVUS, we have done so far about 30 cases in our lab. This slide, we have gone through this in the past. You have IVUS, you have OCT, and the question is, where can you use? It is called as OFDI, which is optical frequency domain imaging. Okay, the OCT is called as optical coherence tomography. Everybody wants to be individual, they want a different name. So that is I think the life. So just remember that if you have left main, try to use IVUS. That's why today we are going to be using IVUS, and of course IVUS can be used for all kinds of lesion, but more important, if you truly have ISR, probably OCT is better to understand the mechanism of ISR, which is there calcium, it is underexpanded, is it neointimal hyperplasia? So to get all this understanding, maybe OCT is better, but of course, if you don't have it, you have you can do with the IVUS. But the question is, when would you need both? Because IVUS and OCT is complementary. So why imaging is important? Before we go that, to assess the lesion severity, okay, we have to use physiology as a gold standard. American Heart Association ACC guideline is class 1 indication, physiology. Same thing with the ESC, that is FFR, IFR, and QFR, the one we just discussed. Everything is class 1 indication. So something, if you are not sure, patient does not have stress test, and you want to understand the lesion, try to do physiology. But then there's tandem disease, exactly in this case, which we can show the angiogram now. Let's show the angiogram. Go to the right. First, let's see on the right. So this is the right coronary artery, non-obstructive, good. And then go to the left. See, our circ looks very good. So when we did this, there's a lot of dampening of this, which is trying to tell us the left main is significant. Next. And this is the LAD. Again, we did not engage. We have wired it and then we took the picture. So you have the LAD stent up to the proximal LAD, significant disease before that septal. There are two diagonals that are stent jailed. D1 is significantly deceased. You see that mild to moderate size, and D2 is okay. Then there is disease after the at the distal edge of the LAD, mid LAD stent. So this is where we are. Go back to the slides. Now this guy has had a previous stress test. Patient has symptoms. So physiology is not necessary at moderate anterior wall ischemia. We already know he has 3 vessel disease in the past. But if for whatever reason, in a case like this, when there is tandem disease, there is some prox LAD, mid LAD, prox circ, OM1, prox RCA, if you have multiple tandem lesion, and in this case, left main, just using physiology may be challenging. More important, misleading. Okay, so many times what you have to do is to take care of the significant lesion and repeat your physiology testing to really understand if those intermediate lesions need to be taken care or no. So then procedural guidance is a separate. One is lesion assessment, second one is procedural guidance. Can imaging help you in the procedure? So again, we have guidelines where you have both ESC as well as in what's called as chronic coronary syndrome. So you can use both IVUS and OCT in true bifurcation, long lesion, left main disease. So we have all of the above here, including ISR. And in acute coronary syndrome, they just use the term complex lesion. So complex lesion means same bifurcation, multiple stents, long lesion, all these things are involved. Then comes just left main, and this one I think I talk about this in every of our live case, that MLA of 6, anything above 6 can be left alone, okay, and anything below that need to be taken care. So that is class 2A. So if you see there, IVUS is a reasonable alternative for left main assessment, and I think in this particular case we are going to use the IVUS. And then comes in ISR, what's the treatment of choice? So the treatment of choice in most cases in instant restenosis, we used to just do balloon and leave them alone, or we used to do repeat DS. So in the repeat DS is still the standard, okay, class 1 indication. So if you see the recent 2024, what the guidelines are saying in chronic coronary syndrome, DCB can be used for DS-ISR, but DS is preferred. When is DCB considered important? That is your multiple layers. If you have 2 layers of stent, if there's a bifurcation, which we are seeing here, maybe you can do the DCB of the side branch and you have long ISR. So that's the case we have here also. So this is a case where we have to have a discussion. Do we re-stent it or do we use a DCB, and what do we do to the side branch? So this is our paper, that instant restenosis management. Imaging is the key, so you understand whether it is mechanical or biological, and based on that, again you have to know whether it is focal, diffuse. Here just by angiography we know it's diffuse, and then we have given you various algorithm to say how to handle each one of this, presence of calcium or absence of calcium. So let's go to the case now. So Amit has already wired it. I think we can image first, right, Kiski? Is that our first thing we want to do?
Yeah, if the hemodynamics is stable, we can try. But if it's too tight, we can balloon first, of course.
Huh?
If the after cluster lesion, if hemodynamic is unstable, we can balloon first.
What a great summary. I mean, what a great case. It brings together so many decision branch points, obviously starting with revas strategy, which I think was explained really nicely, but of course the tandem lesions and best imaging option, and then obviously the technical aspects of Be very interested to see how this case ends up getting done. But a wonderful summary, and congrats to you, Dr. Kinney, in the lab on that first Truma Opus case. That's pretty cool.
Okay, I
Okay,
show
so
the
now
IVUS.
let's show the IVUS live.
Yep.
So I'm in the distal part.
Okay, can you show the
Guide
IVUS?
is outside.
Okay, start pullback. I
It
see
looked
some myocardial breach, very small vessel
Okay.
is coming.
Yeah.
Yeah, this is a previous stand. I see some
Leave
ISL.
it alone.
But looks previous stand looks expanded. Here is a gap.
Right.
Yeah, concentric plaque. Yeah, a lot of neo-intima. And come to left main. Looks tight. Yeah, I'll
left
stop.
main looks-
Yeah, you can quickly take it up.
So distal to the stent is a bridge.
Yes. Here's a half moon sign and the systolic compression. This is
Okay,
a sign
can you
of the myocardial breach.
make it big and show everybody what
Yep.
how does the bridge looks like?
Yep.
Yeah. See that half moon sign? That's a
Yeah.
beautiful picture.
Like 12 o'clock, like 10 o'clock to the 2 o'clock. This like a dark band. This is so-called half moon sign. If you move, the vessel is like compression. So
Okay.
these two signs, half moon sign and the systolic compression.
Leave the half moon sign. I want to make sure our fellows who are watching and for the future, because this comes in your cardiology,
Boards.
cardiology boards and interventional boards also, that half moon sign,
Yeah.
because the goal is to leave them on the medical therapy.
And interesting, there's no plaque on this level, just the bridge and the construction. So no
Okay.
plaque in the myocardial bridge for this patient. Then come proximally, then some plaque start. And I see the previous stent edge. Actually, the previous stent, this is a, I think 2.5 stent. So it's expanded, but concentric plaque. And it's not calcium, slightly lipid. So lipid and fibrous, we can call it a neo-atherosclerosis and neo-intimal hyperplasia. But anyway, it's a biological ISL. Previous stent looks expanded, but concentric tissue. Then come proximally. Then this is the, I think, the diagonal
Second
branch.
diagonal, yeah.
Yes. Then come proximally. Here's maybe okay area. There's area is like 4.5. And come proximally. This is the gap. Then come proximally. Here's another ISL. I see this is a high echogenicity and acoustic shadow. This is a calcified neo-atherosclerosis.
It's a neo-atherosclerosis?
Yeah, because the calcium inside a stent is so-called neo-atherosclerosis. But
Where is that? Before the D1?
Yes, this is the proximal part. So
we didn't see D1, right?
1 second, please. So if you come more proximally, yeah, this is a level of the aorta.
Yeah,
So
left
I
vein.
mean, this is the
Circ,
circ
right?
bifurcation. Then go inside again. You should see the D1 from the same direction. I mean, 10 o'clock.
We don't see it.
I think this is a D1.
Yeah. That's a D1.
So yeah, that neo-atherosclerosis is the proximal to the D1.
Yeah.
Yeah. That
It
part is,
matches the angiography.
yes.
So now going back to your, based on that, since you said it is calcified neo-atherosclerosis, the calcium is probably what, less than 1 quadrant,
Yes,
2 quadrant?
Yeah.
There is a presence of the calcium, but not that severe.
Yeah.
So yes.
So we can just use, I think, a cutting balloon, right?
Yes. Then we can check the IVUS again if we want.
Yeah.
And another point is the left main assessment. So this is again the level of the left main bifurcation. I come back proximally. So this is a distal left main. Even this level, the cross-section area is 4.2 millimeter square. Yeah, some diffuse plaque in the left main. It's kind of short left main, but the plaque start at the osteo left main. Actually, it's not that big left main. It's interesting.
This algorithm is exactly what we are discussed in that central figure of ISR that we published in JAC. So based on all this, right, Kiski?
Yep.
Though the distal part means the distal mid to distal LAD after D2 looks significant, it is a bridge.
Yes.
I think we should leave it alone. Don't touch.
I agree.
I mean, native distal, but there is ISL.
But angiographically it looks significant.
More significant, yeah.
Yes.
Maybe after some medications and potentially treating some of the inflow disease. What a wealth of information from that, starting with the distal lesion, understanding that it's biological ISR distally and not a stent issue per se. There are some questions about the proximal stent. There was a question of it looking underexpanded. Is that, I didn't notice that, but a couple audience members
It is
Curious
a
about stent expansion proximally.
Yeah, I can measure the previous stent expansion proximally. Actually, it expanded 3.0, and this is a 3.0 stent. So, I mean, it expanded as the stent size. But if you measure the proximal LAD diameter, it's 3.8. So it might be some under expansion or just under size. It's expanded 3.0, but vessel size is 3.8 in the proximal LAD.
So let's go 3 to 5 cutting balloon. There, but the left vein, give me the size of the left vein.
Yeah,
I
so
think based on
4,
this,
right?
let us think do cutting balloon and probably one stent from prox LAD to left vein, right?
Costume,
yeah, left main size is like 3.8 vessel EEL.
So we could put a 3-5 stent, and then after that we can post dilate the left main.
Kisuke, are you comfortable with the oblique imaging of the circosteum? It looked great to me, that in terms of the plaque burden of the circosteum as to whether or not they needed to be.
We can see the cross section.
Yeah.
This is the level of the circ bifurcation. I mean, just we can say it looks visually open, but if you're on exact cross section area, it might be better to do this again. But I agree. If it's angulated, it's gonna be the oblique cross section. It's not real coaxial image.
So we did, that's an interesting point. We did discuss, and I am going to show you the slide subsequently also when you have left main, exactly for the reason you just mentioned. You really want to understand, then you have to image both the LAD and circ. But if you see here, left main itself is so small, there's so much damping. Instead of making the case more complicated, you see that? What do you think, Amit?
I think let's see. After the ballooning, we can possibly do a IVUS to circumflex and decide. And for our viewers, I would like to ask you, like, what made you choose 6 French versus 7? Because when you see a left main disease, sometime you may have to plan a bifurcation.
Yeah, no, interesting point. What happened is we do have we did plan that we will probably do 7 French, but then looking at the angiogram itself, we knew the size of the left main is so small that we may have issues just by engaging the guide. And exactly what happened, as soon as we engage the guide, it is damp, and you see the entire case you are doing. He nicely wired it, and
I might
we
add to
cannot.
that while you deliver that balloon for the audience, and you did it so seamlessly. But this is where kind of having a full preparation of your device, your imaging device, and a full understanding of it, such that you can kind of cross. I mean, the patient, I don't think tolerated it so well. But you want to be relatively fast with kind of delivery and your action in a scenario where the guide is giving you problems and it's a lot of myocardium that could get ischemic. That's a cutting balloon there?
Yeah, so you see that a part not expanded is probably where it is, you have the calcium. So same thing, the balloon would not go further. This is a 3 to 5. We are taking this because we had the imaging also telling us the vessel size of the LAD at that level is 3.5. So how do you select a cutting balloon for ISR? So you have a stent, 3.0 means you can go quarter size bigger. So this was a 3.0 stent, right? And then we go quarter size bigger. And plus we have imaging, but yeah, and Will is telling me eyes. So we use your eyes also. So let us go there. I think that's good. What do you think we should do with the diagonal down?
We can see how it looks after this. My bias would be to keep it simple too. I don't think the proximal stent should not cover double jailing the diag would be a mistake, I think, and I don't think it requires that. So unless I
so we are going
misremembering
high. We are going so with this cutting balloon we can go all the way. Wolverine, we went up to 20 now. Okay. Let's take a picture and see. Now that is what we plan. That do nothing to D1. See that, what do you want to do? Kiski, you see that
Yeah.
calcified area
Yes,
not
like
responding.
that area didn't budge. I think, do you want to consider IVL in this case?
So in our own, the publication, if you have calcium inside the stent, usually the rotational atherectomy is the one that helps. If the calcium is outside, which is behind the stent stud, then IVL works because you are able to deliver the waves deeper. That's one. That was the main reason I asked before we started, was the amount of calcium. So it was less than a quadrant. There was no indication for rotational atherectomy here. So we thought cutting balloon will do it, but go back to that area where we saw that.
Yeah, like around here.
Huh?
6 to 9 o'clock, there is a calcium,
Yes.
possibly
Go up.
inside a stent.
Yes, that's what we are trying here. I mean, we can try IVL, but I doubt it will do anything.
Yeah, I agree.
Down.
We have some
Yeah.
questions about how high you're willing to
Down.
go with the cutting balloon in the stent. Okay.
I mean, 18 to 20 is okay.
that's
Not more
fine.
than that. Yeah, yeah. Okay, no need. What do you think? You want
lot
IVL?
of lot of questions
You
about
want
this.
a
What we're going to do with the
imaging?
circ as
We
well.
can
Yeah.
image again.
Let's quickly
actually.
image.
Yeah.
What are the questions now? If
a lo-
somebody tells me I want to wire the circ, yes, I think that would have been the right thing to do. Also, that they want to wire the circ, yes. What's the question now?
Yeah, there are a lot of questions about imaging the circ and kind of how we're handling the circ here. But
Okay. We can do a wire the circ and image the circ. Of course, based just if you see the left main, I think this patient being the vessel size is small. So circ definitely, I think, will be a smaller size vessel. We are going to wire the circ and image the circ. But if you ask me what I would do, means I would not do anything to the circ, and we will just stent across and later on decide. But we can wire and image. Kiski, what is your take?
So yeah, we can check the IVUS, the expansion of that severe calcium part.
Okay.
If it's a resistant, we can consider IVL or Luther.
I'm still impressed by the difference between the distal LAD angio and
Yeah.
intravascular
because-
imaging. I'm really.
I mean, if
Yeah.
somebody sees that
it's
and
hard
we
to-
say we left it alone and didn't do anything, it'll be.
we
we'll
need some
call
kind
it
of
a-
tiebreaker vote there for the IVUS and the IVUS. Yeah.
I think what we can do is just a balloon so that the final picture will look nice. Okay, now I'm going to image circ and LAD both. Okay.
Yep.
And then we make a decision. So the distal part of the LAD stent, you did tell us there is some biological ISR, right?
Yes. Yes. Edge ISL.
Yeah, edge. Not edge. I think. Okay,
I mean,
let's do the
inside
circ
and a
first.
little bit outside is also the plug. Then myocardial bridge come.
What do you want to do there?
Anyway, huge ISL is there. So definitely, I think it's better to open the lumen.
Means
if-
do we cut and do a DCB there?
Yeah, that's what.
I
That's
think
Single
what,
layer
That's a good idea.
and maybe a little bit of drug in the myocardial bridge?
yeah, yeah.
Some we can do a new treatment strategy.
Yeah, I think that is still better than placing another stent in a bridge, I would say.
Yeah, and
Okay.
he's young enough. He's young enough, and he did well with the first couple rounds of stents. But he's young enough where if it represents, you don't want to start getting into the
Okay,
the
Okay,
now-
emergency
image.
point.
Circ.
Okay.
This
Start
is the
back.
previous stent.
Yeah, this is previous stand. It's coming. Okay, expansion. It's kind of under. Yeah, there's a plug at the ostium. Yeah, it's a quick pullback. I stop it. Yeah, so the previous stand looks okay, kind of under proximal edge. And now come to native osteocirc. Yeah, it looks there is a plug. Oh, yeah, it didn't work.
Huh? What happened? Your AI did not work?
Yeah, so it
Huh?
needs me. Sorry.
Misbehaving.
So yeah, looks like cross section area of the osteum is like 2+.
Mm.
Yeah, it's a fibrous and lipid, not calcium, but there's a more than 50%, 60% plaque burden.
That's circumflex osteum.
Yeah, osteum, yes.
Definitely
So what's your take on this?
poses some additional questions. Yeah.
Let's get the IVUS of the LAD. Come,
Sure.
let's finish. One reason I would want to leave the circ alone, I know there's a disease now, we're documented, is we don't know how this guy is going to respond to the stents now.
Yeah,
Right? That we keep placing stent everywhere. He already has one ISR. I told him we give him one more chance. If there is restenosis, he definitely has to go for bypass. Everybody feels we have to take care of the circ. Otherwise, it will be 2 DCB case.
yeah.
DCB to the osteal circ, DCB to the LAD. Oh man.
You might get a phone call later from a bean
Yeah.
counter.
No, like you mentioned, the gentleman has not done very well with the stent so far. I think less
Yes.
metal
Okay.
would be better.
Okay, go.
We
Okay,
can
image.
keep it provisional also.
Okay, this is the mid LAD. Okay, start pullback after cutting balloon. Yeah, definitely bigger. I see some modification. Yeah.
What happened to that
They're still
calcium?
Okay.
Remember, that's where the discussion now. That small area of calcium, and then we can decide.
Yeah, I see still occurs calcium there, but area is already 4.6 cross-section area, and definitely bigger than the initial one. Yeah, here's some modification inside a stand or maybe outside. And yeah, left main still occurs tight, a lot of plaque. But calcium part, I think, bigger than the initial one. Yeah, I think it worked. So.
But,
but
nothing
because
looks like nothing happened to the calcium, though it's only IVUS, right?
Yeah.
Yeah, but lumen is definitely bigger, and our calcium is again it's less than 180, like 1 to 2 quadrants.
120. Yeah, 120.
I don't think IVL is going to help.
I wouldn't use IVL.
Stand and
just stand.
Yeah, I think
okay.
so.
I think we are clear with everything. We will, balloon the LAD and place a DCB. Don't touch D1. Okay. Right. The only thing we don't know is what are we going to do to the osteal circ. The question is if we are using 2 DCB or to no, the cost also, right now we are still $5,500 DCB. So what do you think we should do to the circ?
I think like we planned initially, we can go provisional and we can always change the strategy.
And then we can always drop an FFR wire and feel good about ourselves, not touching it.
Okay. So now we can use we'll do the. Do we know what stent was used in LAD before?
Yes.
Zions. So we have to do the. Okay, let's go to the LAD. Do the DCB first. Come do the left main provisional. What do the viewers think? What do they feel about the circumflex?
Yeah, I mean, some questions about not really committing to one strategy, but how to differentiate whether we want to do a cutting balloon or an NC balloon and then stenting across. There's not a lot of chatter for putting a second stent, just mostly about DCB. And actually, there've been questions about kind of how to execute on that, but we'll get through that obviously, at least at a minimum on the
distal lesion. What do you think? Just go regular balloon, cut it again.
Yeah, I think that mid LAD you want to treat, so let's do that.
Okay, get us a 2.5,
2.5, right? Yeah.
2.5, yes.
Regular balloon. No, not the DCB. Give me a first regular balloon. Let's cut. You want to cut it again?
No, I think non-compliant, like regular balloon is fine.
I would.
Huh? Yeah, tell me what would you want to do?
I probably, if I was going to do that, I would probably do a cutting balloon then the DCB.
Okay.
I think it'll recoil. I think it's going to recoil quite a bit. It's not going to look right. Yeah.
2.5. Give it, and then we can put what size though? 20 or a 30 DCB? I think a 30 DCB.
30 is also fine.
20 because we are to cover that.
That's the Costco version of DCB.
Exactly. When you're opening one, use. Okay, so I'm going to cutting balloon, open the DCB 2.5, right?
That's probably not a bad idea because if you really scrutinize, and I don't recall the IVUS just after D2, there's kind of a 30% plaque.
But that may cause issue with the myocardial bridge, no?
Yeah.
I think 20 would be okay. Let's see with this one.
LAD.
Okay, go up here. We are not going
Yeah.
outside. You see that within the stent. Mm.
I'm at 10, 12.
14, right? Okay, good. Down.
So some
Go up
questions
here.
about, do you have a ratio for sizing de novo DCB? 1-to-1 or some fraction of that?
1-to-1.
1-to-1, yes.
You do 1-to-1 and then same. You go 6 atmosphere, leave 1 minute to, that's it. 1 minute. 60 seconds.
We have
And
a,
that's, I'm going to show some, the steps of the doing DCB. I mean,
Yeah.
so what we also do is we pull back, go back in, thinking the blades can change. Good, go back here. So you're saying 20 is good enough?
Yeah, I think 20 would be okay. This is 6
See,
millimeter.
I did not go outside the stent, which is a bridge.
yeah.
Yeah.
You see that? With a cutting balloon, the risk of perforation always exists.
It's a casually stated point, but it is really on brand for you, and safety
Oh,
is
see that?
such.
It
Oh,
still
wow.
did it.
Section.
Despite
See, this
Yeah.
is low
distal
pressure.
edge. Despite low pressure. So
Hmm.
now how are
That
we
might
going to
change the
handle
strategy.
this?
Yeah.
Yeah, no. I
This is
think we
great.
can still do it. What I want to do is take a long balloon.
Hmm.
What was the size of the LAD there?
So
It's like 2 1/4.
inside a
Distal
stent,
at the level of the bridge?
okay. Here, I
Hmm.
measure again 1 second. Like
We can
2.0
just do a lot.
lesser.
No, 2.5. Get us a 2.5. Yeah, 12.
Yeah.
No, regular balloon. Yeah, compliant. Let's do a long balloon and see how it behaves.
Yeah.
I mean,
I mean,
that's an acceptable dissection,
Yeah, we've seen
which is like can be left alone.
it's uncomfortable to our eyes, but I agree with you that it's not mandatory. That's a lot of questions are being asked about that right now. And by the way, I just want to make a comment. I think our viewership has doubled in the last 20 minutes. Yeah, it's a really, bringing up so many fantastically relevant points to kind of, anyone's type of practice, really. So
Okay, good.
it was a
But this is
well-chosen
a
case.
everyday case.
Yeah, it really is. It really is.
Okay, so now what you do is same. I would have gone 2.5, but I just wanted the viewers to know that if you're imaging and you already have idea. So low pressure, we are like 4 atmosphere, and start the timer.
That's a 2.515 compliant balloon?
Yeah, 2.512 compliant balloon. We are at 4 atmosphere. Is a 2.5, but you saw the diameter. It's barely what, 2.0?
Yeah.
Yes.
Yeah, 2.0. And why 2.0 is a lumen? Show me EL.
Sorry. The level of the compression, again, the vessel EEL is 2.0.
2.2.
Yes.
Okay.
In the bridge.
So at low atmosphere, let's see what it does. Don't ask me to image again. If we have to image and then do the DCB, right?
Yeah.
Agree?
Yes.
So have a 2.520 DCB ready, because that's our goal. And then proximally, I think we should put a 3.528.
Yeah, sounds good.
Yeah.
Agree?
Exactly.
What does your IVUS confirm?
Yeah, same.
Okay. 3.528 up to the left main. We'll leave the wire in the circ. Anybody is for that pre-dilate the circ?
No,
I think let's do a no-touch technique. Just
Yeah,
send
I
across
would,
and see what happens.
there's a lot of other areas for complexity
Yes.
to enter. Let's just kind of not overfill our plate.
We are 90 seconds. Have the IVUS ready so that we are good. Angiographically, if it looks good, we are not going to have the IVUS, okay?
Yeah.
Okay, we have gone down.
Yeah.
Okay, take a picture now.
Ready.
I'm going to
Let's
advance
see.
a little bit.
So that was 60 seconds plus of a 2.5 compliant there. I still, even at this stage, struggle sometimes where my brain and my heart disagree. I'm very tempted to just always put a 258 millimeter stent or something there. Obviously, the bridge is bothersome.
Okay, you know what? Let's do the imaging and then make a decision. Do we put a short stent versus a DCB? I mean, now you see D1 also, because of our cutting balloon, D2 is also misbehaving. So there are multiple things going on there. So keep it simple if you want. Let's image. If it's not too deep, we can do DCB and come out. And this also is a teaching part for the viewers. When can you leave it alone? Now, before you do DCB, they say your lumen has to be less than 30%. Some kind of type A, type B dissections are okay. This is between B and C. It's a little cap, but there is no
right at the borderline.
staining. Yeah, borderline. Yeah. Okay.
I show the imaging.
Quick image.
Okay, stop back. It's coming. Yeah, bridge here. Yeah.
Hematoma.
Just after the stent, but stent is not expanded.
Not expanded?
Expanded.
Okay,
it is
expansion.
Yeah, it looked that way.
And again, left main lesion there. I stop it. You can take it out.
Okay. So I guess DCB
this
is
is
out.
native just after the stent edge. And there's a dissection flap here.
I think we should do a stent then, right?
Yeah,
Look at that.
Yeah. Then, but edge is gonna be on the bridge, so gentle sizing, gentle pressure.
So we have to put a 258 then, short.
Yeah.
Or a 12. What do you think?
Yeah,
I think you'll get away with an 8. Oh.
No, 8 is a border. I think it's about 10 you need, so let's go 12 because
that was a 12. Check out that balloon picture. That was a 12 millimeter balloon. You have that on? Has that saved at all?
But you see, so you are saying just take an.
I think a perfectly placed 8.
Okay.
Okay.
So show me the distal edge of the stent.
Yep. So you see the stent strut here. So
it's good.
Yeah, stent is expanded, but the issue is just after the stent edge.
Yeah. So we are okay. Then we go 8.
Exactly, because even that's our objective is to cover that one single spot. So yeah.
Okay.
So
what happened is the in the view of really expanding the stent, the tip of the balloon probably caused the hematoma, which is. Hey, no. Oh, synergy. Yeah.
Because prior stents are science.
Okay, have a 28 ready. I think so. Then we can stent across.
Yeah.
And even the diags are pitched a little bit. I think they're still, reasonable. Yeah.
Also, it could be that anytime we do, there are certain vessels like that. They dissect as soon as they see a balloon close to them. Some die. Okay, I think you're good.
Yeah, going up. So I'm just going 10 now.
Good.
Low pressure.
Great.
Down.
This is another important point of how you executed that is to deploy at a modest pressure and then pull back just a millimeter or two.
Okay, good.
So that you don't chase your tail by.
Okay, take a picture. Beautiful.
There you go. We can all sleep better.
Yeah. I think two diagonals. Okay, now let's go to the proximal. Let's take a caudal picture to confirm the circ is okay, and then we place the stent.
That was the appetizer. It's time for the main course.
Okay, ready?
Yeah.
Now that we didn't do a DCB there, you want to do a DCB in the circ?
I think that's a
Yeah.
relevant strategy in this
Okay.
one.
So then what was the size of the, so now we have to be very cautious how you
Yeah.
do it.
Yes.
We have a stent there, we have a left main, we are going to stent. You know, the data shows the, if you have a DCB and you restent it, that's when there is, you know, risk of, again, restenosis. Yes. What, Prithvi, what are you trying to say? No, first we do DCB. So this is another question. You do DCB before or DCB after? I would rather do DCB first, stent across, then don't touch the circ. Okay. So then do you go directly DCB? Do you want to
No,
pre-do
I
it?
think we have to pre-dilate.
Yeah, I would
it.
pre-dilate.
Give the same 2.0 cut.
Yes.
Or
It's a
2.5
275 cutting balloon. No, it was a 275 cutter.
Oh,
Give me
right.
the cutter again. Circ, what's the circ?
3.1 EL.
Oh, okay. 275 is okay. And then get us what do you want? 3.0 DCB?
Yeah,
12?
3 would be okay.
Yeah.
No, I
Yeah,
think
short.
let's take longer, no?
Okay.
Well, do you want to deliver
no.
No, there's a
No,
new
because
stent
we are going to
distally and
stent.
then left main. Yeah, I
Yeah,
would take
so you
short.
don't. What is the size you have? No, what is this?
275 cutting
Okay,
balloon.
good. What is the length between the ostial circ and where the
Stent edge
Mm.
is like 12 millimeter.
Okay, see, we said 12 DCB. Oh, we don't have 12? Okay, then only 15. Low pressure. Okay, get the DCB ready and then the stent. And I think it's a good case.
Yeah, that's great.
Good.
It would definitely go. The plan is to go low pressure here, right?
Yes, yes.
Yeah, definitely.
Let's do DCB in at least one area. What size? How high you went?
I went 8 atmosphere.
Okay, go up again.
Yeah, there.
I mean, ideally you have to do another imaging. Okay, make
Yeah,
sure
right.
everything is okay. Then place the DCB, go higher a little bit, right?
Little,
12.
yeah, just,
I think it's better
That's
now.
a-
You see?
yeah, there's a little.
Yeah. Okay. Okay, there. That's it. We are going to make sure there's enough space for that. Yeah, good. Down. Have the 15 ready? 3 or 15, right?
Yeah.
Okay.
There's
Take
a question
picture.
about a Megatron stent here too, which I would be not in favor of, but
Okay, I think it
Very
looks
nice.
beautiful. I
Yeah,
don't
very
think we
nice.
need to image. Let's just place the DCB. 15 DCB. I'm not a fan of Megatron either. Pick
Yeah.
a strut.
strut thicknesses, especially here
I'm
with a provisional plan, and there's not a huge size gradient. I think when there's a big size gradient between left main and, and the distal.
Or you're having a 4.5 and above. That's the
Yes.
time I think you're okay. But
Lot of-
now, in one synergy comes 4.5 above, your Zions 4.5
Exactly.
and above. So
They kind of out-engineer their own product.
yes,
But it's good. It's good to have these tools now. And I will say this is another area I think pre DCB for us. I mean, we would be happy right now just sent across the circumflex, but it's
yes, 100%. But now we have DCB, we can do that. So we're going with the DCB there. I mean, I was said 12, but we're going with the 15.
Yeah.
And have the left main ready. Then we'll image the left main and we can do some more slides. That's it.
15
Okay.
looks good. 15 looks good too.
Going up.
Wait, okay, go.
okay,
Okay,
back
start the
up.
timer.
Oh,
Go,
here we
that's
go.
good.
Okay. 6
Same,
atmosphere.
6 atmosphere.
6 only.
Do you want to show some hemodynamics here too, or
Yeah. That's-
early?
Can we show the hemodynamics in the
Yeah.
side
So,
below?
occurring
Always
left
show
main,
that
so-
because viewers always want that.
Yeah.
Any other questions?
There were questions about earlier, actually, when we were discussing theoretically using, how to use a DCB, how long we inflate it for typically. Generally 60 seconds if it's tolerated.
Yeah.
we
60
talked
to
about
90
this.
seconds. 60 seconds is what they want. But here you see, you can start seeing EKG changes because it's a little bit in the left main.
Hanging in the left.
So I
main.
think, 60 seconds is more than enough.
I
But
think
same, 6 atmosphere, 60 seconds. That's the time you see the drug diffusing. Yeah.
and most importantly, you want it to kind of be your final action there.
Oh, and
ST.
Yeah.
There's no definite guidelines yet. You know, what are the imaging criteria for DCB? We definitely know less than
60 seconds.
60 seconds done. Yeah. Okay, good. 60 seconds done. We take a picture, get the left main stent ready.
Yep. We chose a 3528, right, for that?
Yeah, ready?
Yeah.
Beautiful.
Yeah,
Excellent.
Looks
Yep.
great.
Let's put the stent image. Now we have to post dilate the
Yeah.
left
Or
main
left main.
358 millimeter balloon or 12 millimeter. 35 we have? We don't have
No,
because we
don't
used a
have.
cutter. Get us a 35 high pressure balloon ready. 12. So the proximal LAD stent versus Zions. So we're trying to use a different stent. Now one issue here is we have two diags, right? The D2 has compromised a little bit. D1 is still okay. Issue is this stent may cover the first septal. Essentially what we are trying to say is he may have enzyme elevation.
Yeah, right.
Okay, so that's good. We go cranial. Before you deploy
Yes.
the left main stent, always go cranial. See, one thing that I would tell the viewers, you see the circ wire, it's a U loop.
Yep.
It's not ideal. Never leave a U loop because it's behind the stent. When you're removing it, it can get stuck. We have had here, okay,
Yes.
so it's not ideal. So if I may want to remove, no.
We need a different, maybe an LEO.
No, it's good. I think good.
You think so?
Or even
No.
still quite a bit of sinus overlap, but yeah.
Yeah.
Okay. Now, okay, no. You want it this way, eleocranial.
Kisuke, did we have an entire length of the, that's another way to do it. If you have the entire length of the left main.
Left main is very short, like 7 millimeters.
7, okay.
that-
So
Yes.
about a quarter of our
Come
stent.
back.
I mean,
Oh, no.
yeah, it must come back quite a bit, right?
That was a wrong length now.
But
Because it's
based on
covering D2,
D1.
the D1.
Oh, D1, yeah, right, which
Yeah.
is,
Dr. Kinney, so based on the IVUS, the D1 to the ostium of the left main is 30 millimeters, so it should 28 should cover.
No,
I
it
mean,
was covering
no, that,
already.
how
I
is
mean,
that?
no.
Yeah.
We must be misidentifying because that would be 37 to the ostium, which is way.
Yeah, there you look at it. Some dye there.
I do think you have to pull the thing back quite a bit there.
Some dye. Okay.
Because guide is engaged.
It's difficult to
Yeah, guide's
truly
deeply
understand the
engaged.
left main.
Yeah.
Is okay? Head. We are definitely in the left main now because there's damping. You see that? Okay, some dye. Yes. I think we have to just go in this view. But see that? How can we be saying that?
Yeah.
This is a
No, you're still too far, and you're not covering the left main ostium there at all.
go.
Inject.
Image. Oh, some
Yeah.
dye.
I think you have to come back. You're
Mm.
engaged.
Let's see where the, hold on one second.
Mm.
Yeah, I think you won't. Yeah.
Okay. I think go shorter stent. I would go shorter stent. Okay.
I think, you think so? I think you're okay, but
some
I mean,
dye.
it's coming close to there.
No, see that? Okay.
Yeah.
Because
Seems
there's
like
no
it's gonna,
disease. Yeah.
it's definitely gonna cover the diagonal. Looks
Yeah.
like.
Give me a 24
Hmm.
because we will lose that dye completely. You don't need it.
Yeah. No, we don't need it. 28 is too low.
Yeah, that's a different question of how much was needed, but
You probably need a 26 probably, but okay, give me 35, yeah, 24. Yeah, open. Let's finish the, we are hitting the time.
yeah.
Stop. keep that.
Maybe looking to show where there's a lot of conversation about best view here, but
Yeah, best
I might-
view is
I might-
LAO-cranial, AP-cranial, RAO-cranial, but none of the views are actually showing
I
the
might
left
try a
cranial.
shallow LAO sometimes.
No, straight AP sometimes helps.
Straight AP or shallow LAO. Yeah,
Yeah.
right.
But
But
ideally is a
definitely nothing
cranial view.
caudal, which is
Yeah.
very clear. You can't place the stent in a caudal view. And this looks
Okay,
right. If that's
now
a 24 and we measured
Yeah,
7 millimeters for our,
Yeah, what
that
do you
looks
think?
great.
Looks good actually. Yeah.
No, one other view. You said AP.
Yeah,
straight AP.
I'd like
Yeah.
to see a straight AP or like a 5-10 degree LAO.
Okay, here. This is a straight AP case. You see
Go
that?
a little LAO.
Little bit LAO,
Yeah. Right on the spine, off the catheter. Yeah, perfect.
a little bit RAO.
No,
Okay,
no.
some dye.
No.
This is good, no? You want LAO there?
I want LAO. Yeah, I think if you LAO, you're going to see it really nicely, right? Yeah, perfect.
Yeah.
Okay.
Better.
But you see what we are doing? We are bringing the shutters. You cone
Yes.
in. All the X-rays are now focused into that one little area. This is called poor man's IVUS. Okay. When IVUS is not available, this is how.
We are good. What do you think?
And this stent's a Zions, correct?
Yeah.
Oh,
No,
oh,
this
oh,
is
no.
synergy.
Oh, this
It's
synergy
good.
too. Yeah.
I'm taking a cine.
Okay.
Yeah, I think it went in. No.
No, I pulled back a little bit. It's such a short left.
Yeah.
Somebody hold the stent, fellows. Okay, now you're going to hold it yourself. Okay, good. Go.
Need to come back.
I pull
Still
back.
come back, especially with a synergy stent there.
Okay, now. No. Okay, good. I think you're good now.
Yeah. This
Okay.
looks good.
Go up.
Okay. I'm 12, 14 now.
Good. Yeah.
Down.
I think it's just perfect. Any more in would have been wrong. Yeah.
Okay, good. Down. And then we are going to do the.
I'd make one other point here is you got to
Go.
be very careful when you have a jailed wire and a left main stent because the guide cannot intubate the stent. So it can only damage the stent. You got to be,
Okay, so now get us a 3.5 high pressure balloon. Let's just do that. Now you see I'm advancing the guide on the balloon.
No, but
Okay.
there's a jailed wire, so I can't,
Yeah. Okay, take a picture. Beautiful.
Looks good.
Perfect.
Mhm.
3.5 high
looks
pressure
great. That looks great.
and IVUS.
Yeah.
And we go with a couple more slides that are left over. Any other questions from the audience, viewers?
Oh, some kind of antiquated stuff about putting a wire in the aorta when you stent.
Oh.
I'm not.
It's called the so-called modified Szabo technique.
Right.
Yeah. Szabo has taught it, but has never done it subsequently. Looks like.
That's a ringing endorsement. Yeah, I mean.
Reason I'll tell you. And if go up here, good. And I'm not a fan of ostial flash balloon either. Okay.
Same.
18,
Same.
20.
Unless it's a complete geographical mess.
Yeah, exactly. Means we are going 5 or 6 or left mains and all that, which is rare. So
IVUS.
get the IVUS ready. Go up here, ostium again.
And you're
Wait
comfortable
once
posting, leaving the jailed wire, correct?
Yeah, yes, I will. Okay, down.
I think it's a short segment.
I mean, if there was calcium, we would have been worried. Now I will take that jailed wire and you can take a caudal picture. No, okay. Watch it when it's coming out. Okay, came out, okay. If you think that U-loop was getting stuck, just stop there. Take a 2O balloon and try to, straighten it, yes. Now take a caudal picture for the circ, because circ was our biggest concern. Then a cranial picture, or we can IVUS it. Okay, ready? Go.
Sir looks
Okay,
similar, I
circ
think.
looks
great.
beautiful.
Yes,
Pre-post looks the same.
Yes, exactly.
I was.
During our symposium, we coined a term called IFR. Use your eyes and get a FFR. So this FFR will be, more than 0.9. So we are good. So let's do the left
You
main.
get
So
a
we are
good.
going to do.
I was going to say our distal stent. You can see the distal edge in another view here. We've just to point
Yes,
out in
yes.
this caudal, it looks great.
Do you need the distal stent edge, Kiski?
Yeah, we can quickly check.
Okay. Pre and post.
We can use the fast pullback.
Okay. 20
Okay, check
millimeter
the image.
pullback.
Okay, start pullback is coming. It's a breach and edge of the stent. Yeah, nice.
Nice.
Dissection is covered. Yeah, stent expanded. This is a gap. Yeah, area so far so good.
Let's see that diagonal if we.
Yeah, in the proximal stent. Now come to the left main. And they cover the ostium. It looks perfect.
Perfect placement. Yeah, patient is feeling good, happy.
Yes.
Okay, so now let's do one final. Do you want any more pictures?
I think we can just take final picture.
One cranial,
One cranial,
just to confirm the diacs are okay. There's no EKG change, which is the key. Patient doesn't have any symptoms going on, which is the key. Yeah, and no more dampening.
I mean,
Will is happy.
I'd be shocked if there was a diagonal problem.
Look at that, beautiful. So now the bridge is misbehaving. You see that?
Yeah, right.
Yeah, I think we just give some
Verapamil, maybe?
dilator.
Yeah.
Verapamil.
Yeah, prefer that for bridges, just to.
For the bridge, verapamil.
Yeah.
Yes, little bit of verapamil, and then I think we are good.
Wow,
No.
what a great case! I mean, at every region, there were questions that came up.
Yeah, no
relevant
issues. So
questions that came up. Yeah.
You want one more picture?
Yeah, I think we can just take a 1 second. Let me prime it with the contrast. Yeah, ready. Looks good.
Now you see, no, I mean, I'm a little bit outside, but that's okay. Final picture with the low mag, we always say. Okay,
Yeah.
good job.
Very
Let me
nice.
just see the couple of slides. That's it. Where's my clicker? We go clicker. Oh, here. Let's go to the final couple of slides that we have.
Start closing.
So I mentioned the left main side number, right, which is important also for the fellows, since this question keeps coming in their boards also. So 6 is the number, but then I'll tell you why we are going through it. So this is one of the study. There are several studies. One of the study which actually said that MLA of greater than 6 can be safely left. So if you see there, the upper curve, which is greater than 6, left on medical therapy, and if treated medically, they do have events. Same trial also did what is called as FFR IFR in the patient's physiologically guided decision making for intermediate left main disease. So if you are doing physiology for intermediate left main, like I mentioned earlier, you cannot have disease in the vessels that are further down, which is either LAD or circumflex, because there is a moderate moderate concordance as well as discordance between FFR IFR, and in this situation IVUS is valuable when the physiology is discordant, so you have to have IVUS. So there was a recent what we say the consensus that came out, where they are now going to 4.5 MLA of left main, which we need to be very cautious in this situation, essentially telling that anything that is 4, 5 and less should be taken care. So this was based on the Asian cohort, and if you see there, false negative rate of approximately 24%. So sensitivity positivity was not great in this particular study, and there was limited outcome validation of 4.5 left main that has to be intervened. This is the point, Nitin, that you were discussing, and people were asking that when you have left main, same, because of the way the circ is angulated and all that, it's always good to assess both left main to L, because you need to be coaxial when you're doing a IVUS, right? So
IVUS,
you
yep.
do left main to LAD, left main to circ, then you take your average. So dual, both LAD and circumflex, IVUS is
Imaging, yeah.
very important. Just going to DCB data, do you use DCB or you can use DES? You see that agent which was paclitaxel, if you see that, was paclitaxel coated balloon versus POBA. The reduced, what we are saying is TLF compared to POBA. So compared to POBA is okay, and reduce MI as well as TLR. So the use of imaging was 73%. So pay attention to these numbers. Then is it better than DES compared to the just regular POBA? It was non-inferior. So, that is why the guidelines are telling if it's a single layer stent, you should probably go to the second layer of stent if feasible, but you can consider drug-coated balloon, but it is non-inferior. So mandated pre-treatment was about 98%. So the question is the same, drug-coated balloon versus POBA, which did not, do better than DCB for a single layer ISR. And always, like we showed here, use intravascular imaging, use IVUS to guide you. So you can see in this case, we did the IVUS, we knew it was biological, there was little calcium. If it was significant, a lot of calcium, we would have gone with rotational atherectomy. No, instead we used the just regular balloon. So this is what I think all the viewers were asking us, that when and how to use DCB. There's not definite consensus when to do and all these things. So if in ISR helps to define the mechanism of ISR, which we did, lesion preparation, which is important, and like you see the bottom picture, try to avoid geographical miss, which is the key, which we don't know yet, that with imaging and stent length, that's why we always say the stent length is usually longer than the eye, using your eyes, because you're trying to cover the lesion and going to area which does not have plaque. So geographical miss should be avoided, but we still do not have a standardized, I would say, imaging guideline to say when and how to use DCB. But we have this our apps where DCB is not covered, but of course IVUS and Octade, all that we have discussed today, a lot of it is covered, especially the imaging. Now going back to the final 3 questions of the quiz, if you see here, so if your calcium related ISR assessment, which would be the best one? A, B, C, D. If there is calcium related ISR, which is the best imaging modality? Is it IVUS or is it OCT? In this picture, which one do you think it is? Okay, that is the D. You see that? With OCT, so that upper one is optical frequency domain. And the question is, you may ask, why did we use it? Because of the same color, black and white. If you are using OCT, optical coherence tomography, in the bottom, if you see that calcified neoatherosclerosis and multiple stent layers are predictors of suboptimal lumen expansion, our publication. But what we are trying to say is you can see the calcium very well, okay, and OCT is the best. Of course, we were able to see calcium here today in our imaging, but you do not have Kiski Yakamura in every lab. Remember that, okay? And you don't have these eyes to tell us what is going on. So this is based on which of the following statement about ISR treatment is not correct. Now, PCB reduced TVMI and TLR versus POBA in DES ISR. Yes. Then SCB superior. Yes, right. Agent IDE and solution ISR improved, incorporated in more than 70% of the patient. Yes. And DCB superior
Ooh.
to repeat DES? No. Okay. It is not superior. Yeah. So that's the wrong answer. But remember these numbers only because these questions can come
That's a good
in
slide.
the whatever. Yeah. And not supported by the consortium, which we know what is not supported is that a standardized IVUS and OCT criteria is not established. But IVI helps in ISR mechanism, optimize lesion preparation, avoid geographical miss. So optimal result is residual stenosis is less than 30%, and IVUS MLF more than 4.5 defined successful DCB treatment. No, that's the wrong answer. So we are done with our final question. Thank you.
Wonderful. Thank you, Dr. Kinney. What a great case. I mean, it really is instructive on so many levels. Well executed, of course, well discussed. So I think that was reflected
Any
by
questions that have not been answered?
Like
Oh, I
100
think,
questions.
yeah.
Yeah.
Wow,
There's
Kiski is so happy. He's saying there are 100 questions, and viewers are really engaged, and that's because of the case. And I would say the team, and more important, Nitin, I think you keep them very well engaged.
No, it's a great team here. I really, you guys picked a great case, and I think, you know, even I always learn in these cases. So thank you, Dr. Kinney, to the members of the rest of the team, members of the Cath Lab. Thanks to you all for joining us today for this exciting case. The recording of today's case will be archived on ccclivecases.org later today.
And let's ask Amit if he has any final. Yeah.
No, I think it's elegantly demonstrated the use of imaging, and it's a dynamic decision making. Like you don't stop at one step, and things may change, and then you make your decisions accordingly. I think, which was very well shown.
Yeah, actually, great point, Amit, because what we thought the case was going to look like was different. We were thinking DCB distally, possibly something else on the circuit, and it got reverted largely based on the IVUS, not to mention the other things like the stent length and diameters and things like that. So excellent. Yeah, what a great case. We want to keep discussing it more. I'm sure we will after we get offline. But again, thanks again to all of you guys for joining us. This wraps it up for this morning. As a reminder, Intravascular Imaging Live does occur every other month, and we'll let you know about upcoming cases with the email blast. The next live case will be scheduled at present for Friday, October 2nd. We hope that you all join us for that. Thanks again for the time today. Have a lovely weekend, and see you all next time.
They should also email us or text us what kind of cases that they would like to see in the intravascular imaging.
Actually, great point. Great point. I think that'll help the series evolve. So please do that. And again, thanks to you all.
Thank you.
Thank you.